Hey there, this is Dr. Evan Osar, founder of Fitness Education Seminars, the movement-based solution to the healthcare crisis, and author of the Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. Thank you so much for tuning into this webinar on the Corrective Exercise Solution to Chronic Hip and Knee Dysfunction. If you were at the workshop this weekend, this is your webinar you've been looking for. And if you weren't, and you're just looking to solve your client's chronic hip and knee dysfunction, then this webinar is for you as well. So before we get started as to how we're actually going to correct some of these issues, let's look at some of the myths around some of our current industry practices on how we generally deal with hip and knee dysfunction. So our first myth has to do with the lower cross syndrome, because posture is has such a big effect on the hip and knee. And we get taught, I got taught in school, and we get taught in this industry, that everyone has a lower cross syndrome with it. Pelvis goes into anterior pelvic tilt. We have tight hip flexors and weak hamstrings and weak glutes and over tight low back and weak abdominals. And we blame sitting. But check out these two individuals that are sitting here at the bar here, and then my patient here in my office sitting on a chair on my table. Both these individuals here and this individual here are all sitting in a posterior tilt and lumbar spine flexed. And this is how the majority of us sit and the majority of our clients sit. So if everyone has a lower cross syndrome, how do we go from a posterior pelvic tilt and lumbar spine flexion in sitting to an anterior pelvic tilt in standing? Truth is, it does not happen. And if you look at this fitness professional over here to the right, you can see that she is not in an anterior pelvic tilt. She's neutral and actually slightly posterior tilted. She's lost some of her lumbar spine curve, and she's actually straightened out her thorax and pulled her thorax back behind her pelvis. And this is a lot of us in the fitness industry, whereas this is a lot of our clients that sit for a living. Both this posture here and here, you see the flexion in their lumbar spine and a hyperextension at the thoracolumbar junction. This is not the low back. The pelvis is in a posterior pelvic tilt, and this client, yes, he had chronic hip, low back, and knee problems. So most of our clients are not in an anterior pelvic tilt. Most of them actually tend to be more posterior with lumbar spine flexion, and that directly contributes to hip and knee dysfunction. Myth number 2, we must squat too deep to improve gluteal function. And there's even research studies that show the deeper you squat, the more gluteal activation you get. And this is true if you're just looking at EMG. But if you look at some of the industry experts that say, yeah, caveman squats, the Asian population squats, they don't have any hip and or knee problems or low back problems, but they also squat from the time they're young, and they keep squatting, and they're much more active. Just like this child, he can squat very easily and readily because he's got the range of motion. Most of us lose that range of motion because of sitting too much, especially sitting in that posterior pelvic tilt. And if you look at the research on, or if you look at a client squatting deep, what you'll see is, yes, they may get down deep, and they may come out of that deep position, that squat position, and they may be using more glute, but what are they compromising? And many of our clients, we'll see in a little while, that when they squat deep, they go into a posterior pelvic tilt and lumbar spine flexion, which puts tremendous amount of loads and stress on their spine, low back, and pelvis. Therefore, they get hip and knee problems. Third myth, or I'm sorry, continue the second myth. You see this client right here, she's not even squatting that deep, and she's already going in. Her thighs are barely parallel to the floor. She's already going into a posterior tilt. She's hyperextended through her thoracic spine, again disrupting her curvature. And again, another client of mine, she's about parallel, and she's already going to posterior tilt with lumbar spine flexion, and she's not even all the way down to the floor. So already we're setting these clients up for dysfunction. And if we're doing this kind of squatting with our clients, especially in loaded positions, we are actually contributing to some of their dysfunction. So we'll show you how to fix that. And knee problems. The knee shouldn't go past the toes when we do squatting, lunging, exercises like that. Well, I got a question for you. When you sit down on the toilet, guess where the knees go? When babies squat down, guess where the knees go? Why do we start telling people that the knees shouldn't go past the toes, and we should keep the weight back on the heels and not on the foot, spread out over the foot like it should be? Well, because people weren't good squatters or lungers or deadlifters, so they were getting knee pain because they were shearing too much through their knee. So we said put the knee back and it decreases stress on the knee. And research confirms that. When you keep the knee behind the toe, it actually decreases stress on the knee. But here's a caveat. It decreases stress on the knee, but it increases stress on the low back. So you have to ask yourself, do you want more stress in your client's knees or more in their low back? Or can you improve their mechanics so they can actually use their hips appropriately, use their knees appropriately, and decrease stress both on their knees and their low back? And that's what we're going to look at today in this webinar. So what are the 3 most common hip issues? 1, hip flexor and rotator tightness, mostly from sitting. Also, we'll talk about another reason in a minute. That leads to, hip flexor and rotator tightness leads to FAI, or femoral acetabular impingement. You can see I'm moving this client's leg into internal rotation, flexion, and a little bit of adduction, and that's where you get that sort of groin pinching and pain in there. And that's what's starting to lead to more and more of our labral tears, more of our groin injuries, more of our adductor and hamstring strains, because we don't have good ability to centrate or put the hip in the right position. And when you have too much FAI for a long time, then you lead to the 3rd most common issue, degenerative joint disease. And this is a client of mine who just recently had a hip replacement from too much gripping. We'll talk about that in a minute, because of a prolonged many years of gripping in her hip after a C-section and poor stabilization strategy. So now she has a hip replacement because of these prolonged habits of how she was using her hips. So what are the 3 most common knee issues? Well, chondromalacia patella, when we have wear and tear, uneven wear and tear of the cartilage underneath the kneecap. So some malformation of the cartilage underneath the kneecap. And again, from poor mechanics of how we're using our lower extremities. We can get IT band syndrome. So many of us and our clients have IT band syndromes. Again, poor mechanics of how we're using the lower extremity, and the IT band just takes a beating. And again, if you keep up the chondromalacia patella with poor mechanics and IT band syndromes and poor stability on one leg, then we lead to degenerative joint disease of the knee, and knee replacements being one of the most, if not the most common, joint replacement in the body. So, those are our problems. What causes these problems is poor stabilization strategies, specifically of the Thoracopelvic Canister, so the thorax over top of the pelvis, and as well as the lower extremity. And you can see here in a slide, an image from Diane Lee, that when you overgrip the posterior hip, like many of us do, we jam the femoral head forward in the acetabulum. And this is true of people post-surgical. This is true of people when they've learned exercise, and especially some things that we've taught ourselves as fitness professionals, and what we've taught our clients to do by over-clenching the glutes. And here's what it looks like in a couple of my patients. You see the over-gripping of the posterior hips. It's mostly the superficial fibers of the glute max, and even some of the hip rotators. And again, you see the hollowing divot, and if you palpate the femoral head, or the position of where the femoral head is, it's very anterior in the acetabulum. This is not a desirable look. It may be a desirable look, but it's not a desirable function because you're over clenching. And these are the clients that cannot release through their hips, or they don't release through their hips, and now they start grinding the hip, and now it changes the alignment all the way down the lower extremity, and now you start creating more and more knee problems because now your knees have to make up for the lack of motion that your hips are not giving you. So, the stabilization dissociation model looks at there's certain areas of the spine and body that should be stable, and there's other areas that we should dissociate from. And basically all areas of the body have to be stable at some point, and we have to be able to dissociate or move through those areas at some point. If we look at just globally speaking, generally speaking, the thorax with all these joints and all these ribs must be very mobile and have ability to dissociate through all of these areas, especially for breathing. In the lumbar spine, in pelvis, we're going to need to be a little bit more stable. We still need motion, but we need to be a little bit more stable in that area. In the hip, ball and socket, we need to be a little bit more mobile, but still stable, but a little bit more mobile in the hip joint. Knee, it's a modified hinge joint. We need to be a little bit more stable through the knee. We still need rotation, we still need flexion extension, we still need a little translation, but we need to be inherently stable through the knee. And then the ankle, we want to be somewhat stable through the foot, mobile adapter, but stable through the foot as we load on it, and then be able to move and dissociate through the ankle. So, where do we go wrong? Well, One of the biggest problems we have is when we have that increased hip gripping or that butt gripping that we saw earlier, and increased thoracolumbar gripping that we saw earlier in my patient where he's hyperextended at his thoracolumbar junction, we have loss of low back and pelvic stabilization. That in turn increases gripping. That in turn creates loss of stabilization through the pelvis and low back. So we get this perpetuating cycle. What does it look like in function? My client that I showed you earlier. She has too much gripping in her mid-back, and you can't really see it in this image, but she's got super hypertonic lumbar erectors, and she's definitely a butt gripper kind of girl. And when she goes into her squat, then she starts flexing more and more through her low back instead of being able to move and dissociate through the hips appropriately. And her knees shear way forward because she's not getting enough hip motion and being able to keep her spine neutral enough. Now we can also have problems that affect the knees directly. If we lose either hip and or ankle dissociation, the ability to move through our hips and our ankles, we'll get increased knee dissociation. What does that look like? Well, you see this client, a runner who's got IT band syndrome, hamstring issues. She stands on one leg and you see the knee, her foot's facing forward and her knee's facing that way. That's a bad position for your knee. Same thing in this picture here. This individual's foot is facing to her right, but her knee is facing straight out towards us. So that's a terrible position for the knee, and nothing will injure your knee unless, besides falling on it, will tear up your knees faster than if your foot's going one direction and your knee's going the other. What we have to do with these clients is teach them how to centrate their hips better, align their Thoracopelvic Canister better, and then align the lower extremity and be able to use that in a more fundamental and functional way. And that's what we're going to do next. So our corrective exercise strategy is we're going to look at the principles of what governs proper movement. We're going to look at the progressions. My cute little niece here, how did she get from here to this crazy little girl with the crazy hair and running around and dancing and jumping around? She earned the right. She went through the proper progressions to get to this point. She didn't just go from here to up and running around. She laid on her back, she rolled over, she crawled, she kneeled, she pulled herself up, she wobbled, then she was able to stand up and walk and run and do all the things she can do now at 2 years of age. So our clients, we have to take them back and regress them a little bit to get them to a point where they can actually function in a more optimal fashion. And that means we need to have purpose and discipline about what we do with our clients. So we came up with the integrative movement system as a governing principles of our corrective exercise strategy. Whether you work with the baby boomers, the seniors, dancers, youth athletes, professional athletes, college athletes, principles apply to everyone. Methods apply to some people, they may or may not be used. Principles are governing laws that apply to all people. What are they? Regardless of your population, everyone must breathe better. When we have poor stabilization, because we're not breathing right, we will start to grip. One of the easiest places to grip from is our hips. So when we talked about the Thoracopelvic Canister, breathing will set up proper alignment and maintain proper alignment of the thorax over top the pelvis. Breathing will also allow the development of intra-abdominal pressure, which gives us stabilization, but real important, decompresses the system. Without the ability to decompress the system from an optimal breathing strategy, we put more pressure downwards, down into our hips, down into our knees, down into our feet. And that's why we get so many hip problems, knee problems, and even things like plantar fasciitis, because we're not properly controlling our proximal forces, the forces through the Thoracopelvic Canister. If you think about a soda can, when the top is on, you can stand on this can and it's solid. The pressure inside the can keeps it solid. But as soon as you pop that top, now the can collapses. And that's what our system is like. It collapses under pressure when we're not breathing properly. That's why breathing is so important to set up stabilization. You see the child here, she lies on her back, and when she lifts her legs up, they go up effortlessly because she has a good strategy of being able to be long, and she develops proper intra-abdominal pressure to be able to lift her legs and centrate those hips in the right position. So we're going to use similar positions to reactivate the breathing mechanism as well as restore length and decrease gripping through the hips. And again, if you look at the squatting pattern that we'll use a lot, This again looks a lot like the upright version of this pattern right here. So again, we get stabilization and decompression. Principle number 2, we must maintain an optimal axis of rotation, otherwise known as centration. When we have an optimal coactivation of the forces without too much gripping and the right amount of control, we have a nice center of rotation in the hip socket. When we overgrip the posterior hip, we jam that femoral head forward in the acetabulum, and it looks like this client right here, who's an abdominal, she overgrips her abdominals, that's a hollowing right there. She tucks her butt under, she drives that pelvis, the femoral head forward within the acetabulum. This is a terrible position for the hip and the lower extremity, and that's why so many of our clients have hip, knee, and lower ankle and foot problems. Centration has 2 components. We must be able to centrate or stabilize the femoral head within the acetabulum, and any joint has to be centrated, but in this case, we want to centrate the femoral head within the acetabulum, and then we also want to be able to dissociate the femoral head from the acetabulum. Dissociation just means movement under control. So we must be able to stabilize the femoral head in the acetabulum and then move the leg under control. And that's what centration is all about. And when we lose centration, that's when we start tearing up our joints and we start to lead to our degenerative joint conditions. So in our corrective exercise strategies, we're going to help our client maintain more optimal alignment through their Thoracopelvic Canister. We're going to help them maintain more optimal alignment at the hip and all the way down into the lower extremity. We want to make sure the hip, knee, ankle, and foot are lined up. So in this pattern, I'm going to have the client push down into the floor. I'm going to have him maintain a long spine, and he can just hold it in isometric position there and breathe. We didn't go into breathing here. We have plenty of videos on breathing. That's the first part of the process, and you can find those videos at fitnesseducationseminars.com. Once we taught them how to breathe right, then we'll put them into these positions to get them to activate their hip rotators in an isometric fashion so they start to centrate that joint. As a client gets more adept, or if they have the ability to stabilize, then I'll have them go up on one leg. This is one of our favorite patterns for improving gluteal coactivation and helping runners because it develops the closed chain function of the glute stabilizers and ties the hip into the core into the shoulder. So now you have connection between your shoulder, core, and lower extremity. You can also do kneeling positions where you start to push it against a wall. You can actually push against your client. Have them maintain that nice upward, elongated spine. They breathe into their abdomen, and they line up the hip, knee, ankle, and foot. You can do this in a standing position as well. Teach them where this ideal position is, where the hip is centrated, the knee and ankle and foot are all lined up, and they continue to breathe. Once we taught the client how to breathe and how to centrate the joints, we must integrate them into the fundamental patterns of squatting, lunging, pushing, pulling, bending, rotating, and gait. They must be able to breathe, centrate their joints, and take it into the fundamental patterns. And this is all the great stuff that you guys are doing with your Pilates, your yoga, your CrossFit, your functional training, and sport-specific training, all those activities that you guys do. That's where the integration part comes in. That's your method. What method do you use to now take the breathing and the centration into your method of improving your clients? So the keys to improving hip and knee function: align the Thoracopelvic Canister, and then align and centrate that lower extremity, hip, knee, foot, and ankle. So first, I want to align that Thoracopelvic Canister. I want her to bring that pelvis underneath the thorax, or the thorax over top the pelvis, and align that over top her foot. And I can also have the client self-correct as I'm doing here, and make sure that the hand that's on my chest lines up with the hand that's on my abdomen, and I keep that nice Thoracopelvic Canister as I start to go through my squatting and lunging patterns. The foot is very important to setting up activation from the bottom up. I want to create a foot tripod. I want to get the weight on my big toe, underneath my big toe, my small toe, and my heel. And from there, I'm going to activate the muscles of my medial arch here to create that medial longitudinal arch. And that will feed up my inner leg into my inner thigh, my adductor complex, into my deep lower glutes. And those deep lower glutes are the glutes that are responsible for helping to centrate and pull that hip back into the socket. So if you're an overgripper, you are not using your posterior, inferior medial glutes in an optimal fashion. So that's why the foot tripod sets up that ability to access the glutes appropriately. Now, once we've done that, now we have to relax some of this over gripping. Most of our clients with chronic hip and knee dysfunction have too much over gripping in their hip. So here I have a client feeling behind her hip and in front of her hip. As she goes down into her split squat, I'm going to have her relax both the front and back of the hip and sit back into her right hand. So think about that femoral head dropping back in acetabulum as she goes down. That starts to take the pressure out of her knees and puts it back in the hip. But the weight is not going back on her heel. She keeps the weight on the tripod of her foot. So this is what it looks like from behind. And I also want to make sure that I line up her hip, knee, ankle, and foot, so you can give her a little encouragement if you want to get her to use her VMO better. Again, you want to get those deep medial fibers of the glute medius, or sorry, glute maximus working more appropriately, so I can have her palpate herself and make sure that she maintains a nice squared pelvis, so the pelvis stays level and lower extremity line stays lined up. You can see her knees starting to dive in a little bit here. I want her to bring that knee out just a hair, just to make sure it lines up better so she's not putting her knee in a compromised position. So then we can go into all our lower extremity patterns. Now that we got the client breathing right, lined up right, centrated properly, now we go into our patterns. Knee dominant patterns and hip dominant patterns. So why do you use one over the other? You want to use a combination of all of them, but knee dominant patterns will be better for your back and low back SI joint problems. Meaning like they're going to keep a relatively neutral spine position, and they're going to be able to go up and down squat, lunge, step ups. They're going to use a lot more knee bend than you will in the hip dominant patterns. So for clients that have a lot of knee problems already, the hip dominant problems are actually easier patterns on the knees. But again, the goal of whether you're doing knee dominant or hip dominant is get that lower extremity lined up, get that hip centrated, and get that thoracopelvic canister lined up so they can keep the proper centration of the trunk, spine, pelvis, and lower extremity. So again, bodyweight squat. Again, I'm just keeping my thoracopelvic canister sitting back in my hips, hip, knee, ankle alignment. Same thing in my split squat position. Lunge, whether you're doing transverse, frontal plane, slide board lunges, again, thoracopelvic stabilization, breathing, line up that lower extremity. Make sure that knee lines up down the middle of the foot, and that you're accessing those deep medial glutes. And as you step out into a lunge, the exact same thing on that stepping leg. Step ups, same thing. Load up that front hip. The knee can bend, the knee can come forward, but load that hip up. Make sure the hip is what's lifting the client up. Same thing in a frontal plane step up. Load that front hip or the top hip. Same thing in a crossover. Again, make sure that knee is in line with the hip and lower extremity. Don't let that knee dive in, either as the client sets up or as they step up onto the step. Your hip dominant patterns, a bridge is an awesome pattern, but too many clients just do it mindlessly. Make it mindful. Allow them to use the glutes, lift up till your body is in a straight line or as close as they can get. Keep that thoracopelvic canister. Do not let them grip the hips. Keep the hips soft. Keep the glutes active, but it shouldn't be driving. You shouldn't feel a big divot behind their greater trochanter or in the sides of their pelvis as they do a bridge. Once they get good at it, then create a marching type bridge. Maintain your thoracopelvic canister, activate the glutes, but don't over-activate them where you're squeezing them to death and driving that femoral head forward. They should be active, but not like you're trying to crush a walnut, so to speak. Hip hinge is a great pattern for getting people to dissociate the hip from, or the femoral head from the pelvis, dissociate the hip. So again, they're going to maintain a neutral spine, the thoracopelvic canister, and then hinge at the hip. You can also do this in split stance. You can also do it in single leg for those clients who have progressed. But again, the goal is to create optimal rotation of the pelvis around the femoral head. Keep that foot tripod. Keep alignment between the hip, the knee, and the lower extremity. So all these concepts keep applying over and over to our patterns. This is a great way to work the posterior chain, a great way to loosen up and functionally lengthen the hamstrings without creating overstretching of the low back. Again, once you get into barbell and single leg deadlifts, same concept. Maintain that thoracopelvic canister, hinge around the hip, maintain the hip, knee, ankle alignment, thoracopelvic canister, hip, knee, ankle, foot. Don't worry about if the knee comes forward as long as the person doesn't have knee pain and can control the motion. Make sure you look at them from the side as well as from the back to make sure the pelvis stays neutral and it doesn't rotate. So, conclusion. Problems is too many of our clients are butt grippers. We grip too much through our hips. We have a poor core stabilization and breathing strategy, which makes us grip up even more. We have to teach our clients how to relax. We do a great job teaching clients how to contract. It's just as important to teach them how to relax. Teach them how to breathe right three-dimensionally, get them to relax through their hips, and then go through the principles. Respiration, principle number 1. Get them to breathe right, three-dimensionally. Principle number 2, get them to centrate the Thoracopelvic Canister, centrate their lower extremity. Principle number 3, integration into the fundamental movement patterns of pushing, pulling, squatting, lunging, bending, rotating, and gait. And then follow the proper progressions. Whatever your method is, follow the progressions that allow your client to succeed and maintain the things we talked about through the principles. That they breathe three-dimensionally, that they centrate their joints, and that they integrate it appropriately into the patterns you have them doing. If you're looking for more resources, check out our videos, our free video library at fitnesseducationseminars.com. My wife and I created fitness education seminars to create up-to-date resources for those of you that work with the general population. We work primarily with the general population, so we created all our strategies to deal with the common issues in the general population, the same population that many of you deal with. We go over assessment, corrective exercise, and functional training progressions for dealing with the general population. I hope this webinar served you. I hope it gave you some insight and some tips and cues as to why our clients have such chronic hip and knee problems, as well as a strategy to help improve it. It may seem simple in theory, but it is powerful in practice. This is Dr. Evan Osar with Fitness Education Seminars. Thanks for watching this webinar. We'll catch you next time. Have a great day.